Hi, everybody. Thank you so much for that introduction. I'm Emily Ambinder. I'm a breast radiologist at Johns Hopkins. I'm really honored to have been invited to be here today. I want to thank Modality and MRI Online for allowing me to give this lecture and for helping me put the presentation together. I have no disclosures. This is just an outline for the talk. I know it's a case-based lecture, but I am going to start with a little bit of a didactic section on tomosynthesis. Then we'll move to some screening and diagnostic cases. I'll briefly talk about the utilization of tomosynthesis and then move towards tomosynthesis guided biopsy and tomosynthesis guided biopsy cases. So digital breast tomosynthesis, or DBT, was approved by the FDA in 2011. So with DBT, we acquire multiple images of the breast, which are then reconstructed into thin image slices that can be viewed individually. The resulting image is quasi 3D. It allows us to see a lot more detail than our traditional 3D mammograms. And I want to point out that this is quasi 3D, and often we'll interchange the term 3D mammogram with DBT, but it's not a true 3D mammogram. We're not taking perpendicular slices of the breast like you would have in a CT scan. We're taking angled images across the breast. And this is an image kind of that's demonstrating that. So this is from the Hologic website, but the blue circle represents the breast. And you can see in a mammogram that is compressed between the detector and the compression board, which are in green. The X-ray tube at the top in red will rotate around the patient and take these angled images, and the images are then reconstructed so you can scroll through the individual slices. So what are the benefits of tomosynthesis? So it's really a win-win. So when we are doing screening mammography with digital breast tomosynthesis, we find that we have a lower recall rate by having fewer false positives. We have a higher cancer detection rate by finding more true positives. So it's higher sensitivity and higher specificity. There's not that many technologies that will improve both of these metrics. I can't help myself but just show the calculations for sensitivity and specificity. It's just something really important to understand when talking about especially screening exams. So sensitivity, in order to improve that, would be by making sure that we're really finding all of the true positives and minimizing our false negatives. So that's going to be an improved cancer detection rate. With specificity, we really want to limit our false positives. So that's what we're doing by decreasing our recall rate. So how does the recall rate get decreased using tomosynthesis? Well, as I'll show in several cases, we're really able to mitigate our uncertainties due to overlapping breast tissue when we're using tomosynthesis. There are lots of different numbers kind of thrown up. I think generally we accept that the screening recall rate is decreased by about 15% when we're using DBT for screening mammography. So what about increased cancer detection? Well, with DBT, we're also able to see more detail in the breast, and studies have shown that we have an improved cancer detection of invasive cancer specifically by up to 40% when we're doing screening mammography using tomosynthesis. It's actually been shown to be beneficial in all breast tissue density categories, but it's particularly helpful in dense breast tissue. So now let's start with some cases. So here's our first case. This is a patient who had her screening mammogram with just full field digital mammogram. So she did not have tomosynthesis. And I'm going to just leave this for a second. I want just have you take a look at it and see if you see any findings that might be worth recalling. So this patient was noted to have two asymmetries on her right MLO view. I just have a zoomed in view. This is still that 2D mammogram, the full field digital mammogram without tomosynthesis. And these two different findings were identified. So the patient was recalled for a callback mammogram. In our institution, we always do callback mammograms with tomosynthesis. So I have here her screening mammogram on the left showing those two asymmetries, and then we have the tomosynthesis mammogram on the right. And I'm just going to scroll through it, and I think to just start, just kind of keep your eyes on the lower part of the breast where we saw that lower asymmetry. And when I'm scrolling through, I see overlapping fibroglandular tissue. I see these lines that are crossing in that area of the breast, but I'm not seeing any discrete mass. I don't see any distortion. And And so that finding that we saw on the 2D mammogram just represents overlapping fibroglandular tissue. Similarly, if you kind of look and now focus more on that retroareolar part of the breast where we saw that asymmetry right behind the nipple. Now that I'm scrolling through using the tomosynthesis slices, that appears more continuous with the rest of her dense breast tissue. There is no discrete mass, there's no distortion, and that finding again also represents her normal fibroglandular tissue. So this is a patient who was recalled from screening mammogram for asymmetries, but if she had had her screening mammogram with tomosynthesis, she likely would not have needed to be recalled. So this is another screening mammogram. And again, I'm going to leave this up for a minute, see if you can see any abnormalities on here. So I'm just opening up just showing the MLO and CC views of the left breast now. And I'm going to circle the finding. So this is the finding. I do think you can see it on her. These are the reconstructed synthesized mammogram images. So this is a 2D picture, but it's reconstructed from our tomosynthesis slices. And we see this focal asymmetry or a small spiculated mass in the upper central breast. So although we can see it on the 2D images, I want to now show it on the 3D images and just show how much more clear it is that there is a spiculated mass with some associated distortion. So just pause it here. So I'm going to circle it. It's right here. And then on the MLO view, similarly, as I scroll through, I'm going to pause right here. And you can see this spiculated mass, and while it is visible on the 2D, it becomes much more obvious on the tomosynthesis images when you're scrolling through it that this does not represent overlapping fibroglandular tissue like in the first case, but instead represents a true finding. So we do spot compression views. These are the 2D spot compression views, and again, I do think you can see the finding here, but it becomes much more obvious and much easier to really see the morphology of it when we're scrolling through on the 3D slices. So again, there's on the 2D, and here I think on the CC it's easiest to see. So we see this small spiculated mass in the upper central breast. So when we see a finding like this on a mammogram, we want to see if we can find it on ultrasound, because ultrasound is really the preferred way to do biopsies if we're able to see the finding on ultrasound. So I always look at the finding and try to localize it using the mammogram so I know where on the ultrasound to look. So this is in the upper outer left breast. So you go to ultrasound, we're going to look in the kind of upper central, upper outer breast. And we saw this small mass at that location. It's at the 12 o'clock position, 3 centimeters from the nipple. And there is a small irregular hypoechoic mass with angular margins. This looks kind of a similar shape as that mass that we saw in mammogram. Seems to be in the right position. So what we would choose now to do the biopsy using ultrasound. So here's images from our ultrasound guided biopsy of that mass. So our first image, we see just our biopsy needle lining up before the mass. In our second image, we've now fired, it's gone through the mass. So we usually take several samples. I'm just showing images of one of them, and we place a biopsy clip. It's really important for these types of cases to place a biopsy clip because we want to make sure that this finding on her ultrasound is truly a match for that mammographic finding. So here is our post-clip mammogram showing that biopsy clip in the upper central left breast. And I'm just going to pull up her initial screening mammogram so that we can just look at the positioning. And we do see, so first I have the CC views, and I see that biopsy clip here, and that's right in the same spot where we saw that initial mass on her mammogram. Similarly, I have showing the mass on the lateral view, and again, it's in the same spot as our initial finding on her mammogram. So I feel confident that ultrasound finding is truly a correlate for the mammographic finding. I know my clip is well positioned. This did turn out to be an invasive mammary carcinoma with ductal and lobular features. It measured 6 millimeters in the material cytopathology. So here's our next case. So here's a screening mammogram I'm just showing the side that had the finding. So this patient was recalled from screening mammogram for afocal asymmetry in the inner central posterior right breast. So these are the reconstructed C-view images, and I'm going to now scroll through the tomosynthesis slices. And I think this is a tough finding. You know, I do see that there is an asymmetry there, but I do think that I see interspersed fat within it that makes me think that it could just be her normal fibroglandular tissue. Here on the lateral view, the same thing. When I'm scrolling through it, that finding blends in with the tissue where I think it might just be her normal tissue, but she was recalled. So we did additional spot compression views, and the spot compression views with tomosynthesis are really helpful to show that just represents normal overlapping breast tissue. So here's the 2D spot compression views, and here's our 3D images. And as I scroll through, all I can see is her normal overlapping fibroglandular tissue. When I follow the individual lines, they are around fat lobules representing the fibroglandular tissue, but I don't see a discrete mass or any area of architectural distortion. So this was an asymmetry that was recalled, and with our additional spot compression images, we were able to confirm that this did not represent a true pathology. So this is another screening mammogram, an asymptomatic patient. And I think this is a really tough case to see on a 2D mammogram. I think it's, you know, on our high quality image screens that we use in breast imaging. I think it is possible to see it on the 2D mammogram, but probably on the laptop that you're looking at, it's going to be very subtle. Here, I'm going to zoom in on the side, so you can at least see the side. I'm going to leave it for a second and see if anybody is able to identify an abnormality here. So this is a subtle architectural distortion in the upper, slightly inner right breast. So while I think very subtle on the 2D image, I'm now going to show it on the 3D image, and I think it's much less subtle here. So let me pause so I can circle it. So here's the distortion. It's very hard to see on the 2D image, but the 3D really allows us to scroll through and see that that's a true distortion in her breast that needs to be further evaluated. This is, I think this finding is easier to see on her CC view than the MLO view. But I'm just going to help show you where to look with your eyes. So if you keep your eyes here, I'm going to kind of scroll back and forth through there. And I think you can appreciate how the breast tissue is distorted in that upper part of the breast. So this was a screening mammogram. This patient was recalled. We did spot compression views. Here is our spot compression CC view. And again, I do think that finding it's possible to see it on the reconstructed 2D view, but it becomes much more obvious on the 3D view when we're scrolling through tomosynthesis. So let me again pause here. So the finding is right here in the slightly inner breast. In the slightly inner breast. So here's that finding right here. Similarly, in the MLO view, I think it's very difficult to see it on the reconstructed 2D view, but on the tomosynthesis slices, when we're able to scroll through the finding, I'm just going to draw your attention right here to keep your eyes here as I'm scrolling through. We can appreciate that the breast is distorted there. So this is in the upper, slightly inner right breast. We're going to do a targeted ultrasound to try to find a correlate. So here's our ultrasound This is at the right breast 1 o'clock position. So that's in the upper inner quadrant, which is what we would expect to where we'd expect to see that finding. And we see this hypoechoic mass with some spiculated margins. Our last image here shows internal vascularity kind of at the margins of this mass. So because we were able to see an ultrasound correlate, we did an ultrasound guided biopsy, but very importantly, we wanted to make sure we placed a biopsy clip because again, we want to make sure that that ultrasound finding is truly a correlate for the mammographic architectural distortion. So here's our biopsy clip, again, in that upper inner right breast. I'm just going to show the CC view because I think that's where we can see the finding easiest. So here's our biopsy clip, and that was where the distortion was on our initial screening mammogram. And so that clip was well positioned. It was well positioned in the MLO view also. So we feel confident that the sonographic finding is truly a correlate for the mammographic finding. The pathology for this was an invasive ductal carcinoma, histologic grade 2 of 3 with associated DCIS. Another screening mammogram. This was a case that was recalled for a possible architectural distortion in the right breast. So sometimes we'll see on a full view an area that we question whether it's truly distorted or not. We want to have them come back to take a closer look. So this was identified by the radiologist reading the screening mammogram. I'm going to show now the 2D images. I'm going to scroll through and see if we can appreciate any distortion. I'm going to circle. This is where the finding was on the 2D image. But when I'm scrolling through now on the 3D imaging, and I'm following individual lines, I can scroll in and out of that area, and there's not any single slice that I can pause on where I see a true architectural distortion. So I think what we saw on that initial 2D mammogram was just the summation of normal overlapping tissue. We did a Spock impression view also, and similarly, we see normal overlapping fibroglandular tissue. There's no area that I can pause on where I see a true architectural distortion. So this is another example of how there are many findings that with tomosynthesis we can clarify as being normal tissue and not pathology without requiring a biopsy. We did an ultrasound at this area. We showed normal breast tissue, and the patient was returned to screening. This is the next case. I just have a CC view. I have the reconstructed 2D mammogram on the left, and then the tomosynthesis image on the right. And I think this is just a good example showing this patient has a very dense breast tissue, particularly in the kind of central to outer breast. But it's hard to see if there's anything in there. I mean, I think you can sort of make out that there might be an edge, like where my mouse is here, but it's very hard to make out because the breast tissue is so dense here. But let me show you when I scroll through on her 3D mammogram, it becomes much more clear that there is a mass in the retroareolar breast, and potentially even multiple masses. So I can see this edge here representing one mass. There's another one slightly more outer in the breast. When you go back and look at that 2D mammogram, I think I can see where those masses are, but they're very hidden by the dense breast tissue around it. And the 3D mammogram, the tomosynthesis slices really allow us to scroll through and tell for sure that there are some findings in this breast that need to be further evaluated. So this patient had an ultrasound done, and luckily that these represented simple cysts. She had several simple cysts in that outer retroareolar and outer part of the breast, which correlated with the mammographic masses. So just shifting gears briefly. So I have a interest in access to breast imaging, and part of that is the utilization of breast imaging. So our group did a study recently looking at the utilization of tomosynthesis at our own institution. So we started doing breast tomosynthesis in 2013. And we found that although most insurances do cover it, not all of them do. And we saw that we were hypothesizing that there were disparities in who was actually having their screening mammograms performed with tomosynthesis. And this is what we found in that study. So when starting in April 2013, when we first started doing screening mammograms of 2013 with tomosynthesis, we saw a pretty dramatic increase in utilizations from 19% in the first year up to about 90% currently. But at all the time periods, we saw differences based on patient's race, with a disparity between white patients being more likely to have their screening mammogram performed with tomosynthesis compared to Black and Asian patients. So I think this just highlights that there is definitely work to be done to make sure that this modality is available for all patients. I'm going to move towards tomosynthesis guided biopsy now for the second part of the lecture. So before we can talk about tomosynthesis guided biopsy, we need to make sure everyone's on the same page with stereotactic biopsy. So historically, mammographic findings that did not have a sonographic correlate have always been biopsied with stereotactic guidance. So with stereotactic biopsies, we take a paired image. These are two images that are taken at a plus and minus 15 degrees from the scout image. And that's used to determine the position of the finding, specifically the depth of the finding. But now we've been doing all of these mammograms with tomosynthesis. And there are many findings that are only seen or best seen with tomosynthesis. And so what do we do about those? So before we had the ability to do tomosynthesis guided biopsies, it was really a problem to try to figure out what we should do. So these patients were either recommended to go straight to surgery, and we would use tomosynthesis to localize the finding, and then they would do a surgical excision. Or we'd also sometimes we would evaluate these findings further with MRI. But if the MRI is negative, you're still left with this finding that has not been fully resolved. So luckily, tomosynthesis guided biopsy was started to be used, and this allows us to biopsy findings that are either best seen or only seen on tomosynthesis imaging. So our group started doing this, and we had a lot of success with it. There were some early studies that with high technical success, they showed shorter procedure times. But after we had done this for some time, we thought there was still limited data in the literature, and it was reasonable for us to look at our own experience to try to help show whether this has been a successful or not. So most of the cases of tomosynthesis guided biopsy were for architectural distortion. So that was the first project that we did. We looked at all of our cases of architectural distortions that did not have a sonographic correlate and were biopsied with tomosynthesis guidance. This was published in AJR a few years ago. The study included 151 unique architectural distortions without a sonographic correlate. We found that 19% of the cases were malignant, 32% were high risk, and 49% were benign. Most of these malignant lesions were invasive carcinomas. And interestingly, most of the invasive carcinomas were lobular, which is overall much less common than ductal, which is the most common type of invasive breast cancer. The high-risk lesions most often represented radial scars or complex sclerosing lesions. And I think this just emphasizes that we really want to make sure that these distortions, even if they don't have a sonographic correlate, are biopsied, since 19% of them represented malignancies and another 32% represented high-risk lesions. We did a follow-up very similar study looking at developing asymmetries. These are not distortions, but are still suspicious findings, again, that did not have sonographic correlates. This was published a couple of years ago in Radiology, and we included 85 developing asymmetries that did not have a sonographic correlate, and we found a very similar malignancy rate of 20%. And almost all of those malignancies were invasive carcinomas. So again, this highlights the importance of biopsying these findings, which are suspicious on mammography, even if they don't have a sonographic correlate. So now moving into our biopsy cases. I'm showing here a prior mammogram and a new mammogram. I'm just going to leave this up for a few seconds so that you can take a look and see if you can identify the abnormality. I'm now showing just the MLO views, the current in the prior. And we see new density in the upper left breast. And this is just a 2D view. I'm going to show the 3D views where we can do a better job of evaluating whether it's distorted or not. But here's the CC view. And I think that the two CCs next to each other can really help to show this developing finding. I'm now showing the tomosynthesis slices. So here's the CC view when we see this developing asymmetry with artificial distortion in that posterior breast. Similarly, on the MLO view, in the upper part of the breast, we see this developing asymmetry with associated distortion. So here's the finding on the MLO view, and then here is the finding on the CC view. So just like for those cases that I showed earlier, this patient had a full workup. So we did spot compression views. Here's the CC and MLO spot compression views. I think you can see that there is an asymmetry, a focal asymmetry on the these reconstructed C view images, but on the tomosynthesis images, I think we can really appreciate that there is an architectural distortion that's associated. So here I'm just going to circle it with my mouse here so you can see where I'm looking. And I'm going to scroll back through that finding. And then similarly on the MLO view. We can appreciate that there's a distortion in that upper part of the breast. So like the cases I showed earlier, this we would recommend doing a targeted ultrasound. So we did the ultrasound and just showed normal breast tissue. We could not find a mass that correlated with that finding, but this was a suspicious finding. We wanted to make sure we biopsied it, so we recommended doing a tomosynthesis guided biopsy. So here are our images from the tomosynthesis guided biopsy. So this is a CC from above biopsy because the finding was in the upper part of the breast, but more centrally on the CC. So we generally choose the direction that's going to make the needle have to go the shortest distance within the breast. The first picture here is our scout view. So on the scout view, I'm going to scroll through the finding and find on which slice I can best see the distortion. When I've identified the finding on the tomosynthesis slices, I'm going to click on it, and our software will then give us coordinates. So the X and the Y are going to be based on where on the image I'm clicking. Our Z axis is going to be calculated by which slice I'm clicking on. This is different from the stereotactic cases where we take angled images, and then the computer software will use geometry to determine what the Z axis is or how far in we have to put the needle by using those angled images and where the finding is on those angled images. Our middle image here is our pre-fire image. So I always take a pre-fire image, and we want to show that that needle is lined up just at the lesion. I think that this is a very hard thing to show on a PowerPoint slide, but I see the finding here and I see my needle approaching the finding. This is in the pre-fire position. The finding is often obscured on a post-fire image, so I don't always take one. So I don't have a post-fire image here. I just have the pre-fire image. We always want to put a biopsy clip in. So similar to the ultrasound biopsies, that clip is really helpful to make sure that the area that we saw on those full views is the area that was biopsied. It's also helpful for localization when if the patient needs to go to surgery. Even if the biopsy ends up being benign, it's helpful to know where it was that we took those biopsy samples so we don't in the future feel the need to biopsy it again. So we put the clip in. We usually do a 3D post-clip mammogram. I see here there's a top hat clip right at the area of architectural distortion. After I place the clip, I usually pull my needle back a little bit to make sure that there's separation so I can really see the biopsy clip separate from my biopsy needle. So I can see that here. So here is our post-clip mammogram. So when I see that that biopsy clip is right in that area of developing asymmetry with distortion in that upper inner left breast, right in the spot that I expect it to be. So I feel confident that I biopsy that's the correct finding, and that my pathology is going to represent what the pathology is at that site. So this case was an invasive lobular carcinoma, grade 2, measuring 1.1 centimeters in the material. So this is a good example, like I had said in our paper, where we looked at all of our architectural distortions. We found most of the cancers were invasive carcinomas, and more than half were invasive lobular. So this is an example of an invasive lobular that presented as a distortion without a sonographic correlate. Here's the next case. This is a tricky case. This was a showing the left. This is actually an XCCL view, so an exaggerated CC view. So you can see the outer breast well, and an MLO view. So this patient has lots of surgical clips in from a prior lumpectomy, but she was noted to have a new focal asymmetry at the lumpectomy site, and I think it's better seen on our spot views. So I'm just going to go to the spot views here. But you can see there's a small mass or focal asymmetry here in the upper outer left breast, very posterior depth. This is new compared to prior exams. The patient had had this lumpectomy many years ago, and so was considered suspicious. It's a very, very small finding, but regardless, we still recommended doing an ultrasound. Oh, let me just go ahead and show our tomosynthesis slices here. So here is on that XCCL view, you can see this very small mass. And here's our MLO view. And we can see that mass on the MLO view also. And again, this was new compared to her prior exam, so was considered suspicious. We did an ultrasound, and this one we did not able to find a sonographic correlate for that finding. So a new finding at a lumpectomy site is considered suspicious. We want to make sure we biopsy, and so this is another great example of where we can use tomosynthesis guided biopsy. So here is our scout image of our tomosynthesis guided biopsy, and this was challenging. It was very posterior in the breast. And it took a while, to find the area, but we found this asymmetry here, and so this was what targeted for biopsy. So we did the biopsy, and like I have repeatedly said, we placed a clip to mark where it was that we took the biopsy from. So we did that post-clip mammogram, and we saw the biopsy clip. But as we looked at the case after doing it, we saw that she still had that small mass in the upper outer breast, further posterior from where we had biopsied. So we spoke with the patient, and she actually was willing to just have another biopsy done that day. So she came back to the biopsy table. We did another scout image here. And here's the biopsy clip from the first biopsy. And at the very, very back of the screen, we saw this other mass here. So it was close, but if you remember from our first biopsy, this was at the very back of our biopsy window. It's a small window that we're able to look at where we had biopsied. So with this other area was not in our initial biopsy window. We then biopsied the second area on that same day. We put another biopsy clip in, and that was in the correct area on her post-clip mammogram. We got our pathology back a few days later. That first biopsy site was benign breast tissue with associated rare microcalcification. That second spot, when we had her come back and biopsy the initially described suspicious finding, represented an invasive ductal carcinoma, moderately differentiated with mucinous features, measuring 5 millimeters. And there was also associated microcalcifications. So I think this is just a great example of why we want to make sure we're looking at that post-clip mammogram image and making sure that the finding, whichever modality it's being biopsied with, really matches up with our initial mammographic finding. What about tomosynthesis guided biopsy of calcification? So, we talked about stereotactic guidance before, using that plus and minus 15-degree images to localize the finding. And although, I've only talked about biopsying like distortions and asymmetries, really that's been primarily used to biopsy calcifications. But once we started using 3D biopsy for these other findings, we also started using it for calcifications. And anecdotally, I think people in our group really enjoyed using it. They felt like it was quicker. We took fewer images. There had been some studies on the use of it, but there hadn't been very many. So we decided to look at our own experience with tomosynthesis guided biopsy of calcification. So this was a paper published pretty recently, this past year, in AJR, where we compared our diagnostic mammography guided biopsy or the traditional stereotactic biopsy with tomosynthesis guided biopsy for suspicious breast calcifications. We included over 1,300 biopsies in the research study. And we found that we performed almost 3/4 of our biopsies using tomosynthesis guidance and only about a quarter with stereotactic only guidance. And I think that really speaks to just our radiologists were very comfortable using tomosynthesis guidance and felt like it was working well for them. When we compared these two groups, the tomosynthesis guidance group with the stereotactic guidance group, we found that the procedure time and the number of exposures was significantly lower when we used tomosynthesis guidance compared to the stereotactic guidance, and it was statistically significant. We did not show any difference between biopsy outcomes or high-risk lesion upgrade rate. We want to make sure that we're still diagnosing as many similar numbers of cancers, we're not under-diagnosing cancers or finding that more of our high-risk lesions are being upgraded, but we didn't find any differences in those outcome metrics. So with that in mind, I want to next show a case of suspicious calcification. So here are magnification views of grouped coarse heterogeneous calcifications in the upper outer left breast. So unlike all of the other cases I've shown, calcifications are best visualized on magnification views. The tomosynthesis is not typically helpful in evaluating them. But we did do this biopsy using tomosynthesis guidance. So similar to the other cases, we have our initial scout image where we take a set of tomosynthesis images through the area. Here are our calcifications. It's important to scroll above and below the area that you're intending to biopsy to make sure there's not a vessel in the way. And that's something that's very helpful with tomosynthesis, that you're able to do that to see for sure that whether or not there are biopsies above and below the finding. Here's our pre-fire image. And I see my biopsy device lined up just in front of those calcifications. So I'm making sure that they didn't move when I did my numbing medicine and placed my biopsy device in. After I took the samples, we place a biopsy clip. Here's the biopsy clip. We see again, it's lined up exactly where those calcifications had been. I pull back my needle a little bit to make sure to see separation between the biopsy clip and the biopsy needle. When we biopsy calcifications, while we're still in the room with the patient, we take a specimen radiograph to confirm that enough calcifications have been removed in order to come up with a definite answer. So here's our specimen radiograph showing representative calcifications in the specimen. And this did represent ductal carcinoma in situ, grade 2 to 3 out of 3. So in summary, digital breast tomosynthesis has really changed breast imaging in the past decade, or a little bit more than a decade now. We see improved recall rate and improved cancer detection rate, and we're also able to biopsy findings using tomosynthesis guidance, which is very exciting. And this is more of an evolving area.